So that's my question. What are the roots of...
The roots of community-based healthcare?
Yeah.
Well, to the best of my knowledge, the first person who really got this started was a man called John Grant, who worked with the Rockefeller Foundation in the Peking Union Medical College in China in the 1920s. The Rockefeller Foundation set up a first-class medical school to train doctors and, broadly speaking, public health, people who would get into the more broader public health. John Grant and his colleagues were determined to go beyond the one-on-one clinical practice to the getting out into the villages, which we can call communities. Because that is the vast majority of people in China and most of the rest of the world. And so one of his colleagues worked on literacy. So what units did they deal with? They dealt with communities. So they thought and acted in terms of getting every child literate. And they would go into a village and find out the leaders and there's a school, work through the school, to get to every home, to get those children. John Grant was hand in glove with people doing that, and he saw that as a very sort of a way of broadening and underpinning this particular health approach. So the question of how to teach the parents to encourage and be teachers of their children in terms of literacy, that's the same principles applied to his approach to the sicknesses that they were having. I mean, everybody knew that the diarrheas were to do with a lot of them to do with water supply and the infection of infected water supply. So that they would be not only wanting to treat the diarrhea, but very much to prevent it. And how did they find that to undertake to do this? Through the medium of village-level workers. These are ordinary village people who are carefully selected and trained in their particular job to go and visit people in their homes or at their place of work and find out from them what their problems are and what are their priorities. And through this approach of using village-level workers, they were surprised and gratified to find out how much these people could do with the right backing, supervision and encouragement. Well, by the time the Second World War came around, John Grant then transferred to India. He escaped from China before the Japanese could catch him, and went to India, and there he developed community-based approaches in India through the new All India Institute of Public Health. And he set up a whole range, a number of district level, that is a few 100,000 people who are administrative districts in India. They started a health system and, you might say, a development system to an extent, to try out how this works under the aegis of each local state government. Various other people all in the world took this up, very much, I believe, through the aegis of through the medium of the Rockefeller Foundation. One of these people was a man called John Gordon, who came from Minneapolis, I think. He studied microbiology, and then he moved from there to medicine, and from there in the 1930s he took to communicable disease, and he was head of the Detroit Fever Hospital. In those days, every major city in the Western world had a huge hospital for dealing with communicable disease. The common communicable diseases: chickenpox, smallpox, yes, measles, whooping cough, and so on, diphtheria. And there he started to realize to get some idea of the relationships between nutrition and infection. Then after his next stage was to move to the Rockefeller Foundation. They asked him to be a scientist working with them. And what he had always been wanting to do was to document an epidemic of scarlet fever from the first case, which means that he had to have his people there in this location before the first case came. So he chose the country which then in the 1930s had the highest rate of scarlet fever, which turned out to be Romania. And through the government he had access to simply trained people whose job was to go house to house and find out about the children particularly, and if anybody starts to get bad sore throat and fever, then they were docketed as possible cases, and they found out on further home visits where it did turn out actually to be, and they swabbed the throats to find the streptococcus that causes the scarlet fever. Now, an unfortunate thing happened. Somebody stole his records, so he never really published this. But while he was there, now in the middle to late 1930s, he had a visit from the Chief Medical Officer of Great Britain, Ministry of Health, who came to visit him to see how he was studying epidemics. The Ministry of Health at that time was concerned that Britain would be in war before long, and that there would be bombing and interruption of water and mingling of water and sewage and so on, and that there would be a recrudescence of the decennial, the 10-year flu influenza epidemic, which had come in 1898, 1908, 1918, this enormous epidemic which flew worldwide, in 1928, but hadn't yet come in 1938. And so they're expecting it in 1939. They wanted to have a place, an instrument in place that could identify the causes of unrecognized epidemics of new disease, apparently new diseases. But then eventually 1939 came, and John Gordon by this time had moved to Harvard Medical School, and the president of Harvard University told Winston Churchill that whatever Harvard wanted, they could have.
Whatever Britain wanted, Britain wanted from Harvard.
They could have it.
Right.
And at this time, it was 1939, the war was on, and so they said, we want John Gordon. Send John Gordon was the cable that came back. So he went to Britain in 39, and late 39, and set up a hospital and had the staff with the capacity to go out and investigate any unrecognized epidemic in Britain. Later still, the Americans came in the war, 1942, and John Gordon was made Chief of Preventive Medicine for all United States forces in the European theatre, and later he did the same thing in 1945 for General MacArthur. So in this capacity, John Gordon had access to every military unit. He knew them; they knew the numbers of persons there for however many years, months or years, and whatever conditions, problems that faced them. He applied his epidemiology, which formerly had been applied only to infectious diseases, to other things like accidents and mental health and frozen foot. And so he developed an epidemiology of non-communicable disease and all problems, maybe not diseases. Subsequently, after the war, he was at Harvard, back at Harvard again, and publishing this and getting very angry reviews from epidemiologists who didn't like his idea of non-communicable disease epidemiology. There was one of the great discussions was on the population issue in the world, the rising numbers of population. And so the Harvard School of Public Health faculty had great discussions, and nobody could come to any conclusion as to what they could offer except John Gordon. who realized that he could study the population dynamics, the birth, deaths, and migrations that are occurring at the local level, which are the fundamental basis of the population problem, of the relationship between birth rates and death rates, and the rapid growth of either small communities, from small communities to whole nations and the whole human race. So the chance came when one of his former students, Carl Taylor, came to work with him to take his doctoral degree, and another member of the medical faculty, Dr. Clarence Gamble, had been working on birth control for many years, and Carl Taylor published an article in the Atlantic Monthly on will India's cultural patterns permit the use of birth control. And Clarence Gamble read this, went to see Dr. Gordon and Dr. Carl Taylor, and asked them to undertake a study to see if they could change, it's possible to change birth rates in, say, rural India using simple methods. And they thought it was a good idea, so he asked Carl to undertake it, but Carl said no. He's going to start a Department of Preventive and Social Medicine back in India. And John Gordon undertook to train somebody. So the question was then, who should they train? And Carl said, he said, yes, I met a man called John Wyon in India 2 or 3 years ago, and I think he might be the right person, because he's had 2 years, 2 years following his medical qualification in Britain. He had 2 years in Ethiopia, where he was the only qualified doctor for the whole province of Tigray, 1 million people. And he and I have had talks, and his question was how might it be possible to apply the principles of scientific medicine to poor illiterate people, and large and huge numbers that there are throughout the world. So Clarence Gamble gave the money for this John Wyon to come to Harvard, take his MPH with John Gordon, and then the two of them would set to work to design the study. Well, this occurred, and Dr. Gamble funded the first 2 years, and the Rockefeller then, and the government of India, the Medical Research Council of India, funded the rest of the study, which altogether took 7 years. Now we were applying John Gordon's community-based non-communicable disease epidemiology of the levels and determinants of rates of birth, death, and migration, and therefore the whole population growth of the village population. For many years, I wondered where John Gordon got the idea of the community-based approach, and I had a sort of feeling that John Grant was the person that he had, from whom he had learnt this principle. Exactly at what juncture, I don't know, but presumably when John Gordon was a member of the Rockefeller Foundation staff, he would be aware of what was going on in China at that time, and this was in the 1930s.
So he was aware of John Grant's work and Carl's understanding of John Grant's work, and therefore would have heard more about what happened in China, both from John Grant directly, but certainly from Carl.
That's right.
And so he was learning.
Yeah.
How far did John Gordon take the community-oriented or community-based approach during his career? By how far, I mean in terms of method development and what was left to the next generation.
He was primarily a diagnostician. His great contribution was the diagnosis of exactly what is happening to whom, how, why, and searching, of course, for the basis for preventing or curing the particular problem in mind. And this community-based approach gave him a method to address these two conceptualize and address these problems in a very rich way, a richer way than he had before as a doctor working in a hospital. He was very clear that the determinants of epidemics are to be found in the person and in the community and in the environment. Until I had started working with him, I never had thought of any of this epidemiological issues. So I owe to Gordon entirely my understanding of that. Was one of the things that I was looking for, but I didn't know what it was in the early beginning of the 1950s. When I talked with Carl, these are the scientific methods that I didn't know existed at that time. But this has turned out to be a scientific method which has been a beacon for me all my life since then. I was completely committed by 7 years collecting all this data with all those wonderful people that we worked with in India to analyzing it, and we started a great deal of analysis using edgemark cards, card sorting by hand in India. But now the computers were just starting to come in those days, and so we were transferring now to punch cards, IBM, and of course making much easier the analysis of the data, all the detailed data that we collected month by monthly visit to every family in 12,000 people for 5 years, which turned out to be an absolute mine of information about birth rates, death rates, and migration rates, which had never been done before. And we were coming out, finding what we sort of suspected already, that, for example, that tetanus of a newborn was killing major numbers of children, and the medical and public health profession in India had no idea that was so, because when the babies got sick in the first few days of life, people could recognize what was happening, and they said there's no point in taking them to the hospital, so they didn't. So the medical profession and even the public health profession had no idea of this problem. The same thing was a very similar problem was to do with diarrheas. Diarrheas turned out to be easily the commonest causes of death in the whole population, but they were mostly occurring in the first 2 years of life. Nobody else had any inkling of the enormous toll of the diarrheas. Well,
right. I didn't realize that.
Yes. So there were eye-opening, really major findings which translated virtually to the whole world, the whole poor world. But now they have the means to deal with it, which was invented on the basis of a huge field study, community-based field study, started in what was then East Pakistan. Then East Pakistan became Bangladesh, and this huge project of working in 200,000 people in Bangladesh on diarrheas became the International Center for Diarrheal Disease Research. One aspect of their work was not only field work, but also clinical work,
yes.
And they measured the actual quantities of diarrhea that children, people, and adults were producing, and then they could measure how much fluids had to be put back into the people to keep them alive, because they were dying of dehydration. And so they found, yes, they could do it by the intravenous method. But then they went beyond that and said, let's try and see if we can give fluids by mouth, which they found it to make a very simple solution of salt and sugar or carbohydrate and water. And this became applicable at the village level. So every mother in Bangladesh is now taught how to make these solutions and give them to their children. They don't need a hospital. And so this is called oral rehydration therapy. And it's being practiced all over the world, saving lives of millions of children. We were trained as doctors, and we were very. I came from when I was before I was a medical student, when I was still at high school. I was much interested into pond ecology, an ecosystem. And Gordon was very important for him to think about the environment, the ecosystem, in all its biological, physical, and social aspects. Many of us had come, into medicine with broader ideas than just looking after individual patients. But nevertheless, as medical students, we were taught to understand the human body in great detail, and in sickness and in health, or in health and in sickness, and then how to treat and how to take care of, and then at a further level how to prevent. And so we'd all been in some way or other. We had been sort of playing with the idea of communities. It had been entering into our consciousness. When I was working in Ethiopia, and when I was working in India as a doctor, so I did the mission doctor for 3 years, one was so aware of the millions of other people that you were not, that were out there also. So the question of how to reach these millions was something which was at the back of our minds. Sydney Clark in South Africa, the millions of Africans and of different communities, each with their own cultures and ideas on witchcraft and all that stuff. Each of which are it's so important to have a way of understanding and being able to enter into the thinking and the actions of these people and their relationship to health problems. So I think it's not really unremarkable that different people in different places have cottoned on to the community-based approaches. When I started teaching, I was now in the new department of population sciences, and to which the community-based epidemiology was, to my mind, one of the fundamental sciences that are relevant to that. So I chose to run a very similar course in which the students chose a community and then some aspect of population dynamics, which is either to do with birth rates, death rates, or migration rates, or some combination of them. And they did go through the same process. And in both cases, each student had a faculty member to work with them, so that there was a great deal of personal interaction between the student and the faculty members and other people with experience. And they were encouraged to go and speak to anybody in the whole university or beyond the university and to get information and so on from any source. But to bring it all to get into focus of a particular set of problems concerning a particular community, and how they could make a contribution to further enlightening us all about those problems in this kind of community.
And so now just to take this a little one step further, since I was asking how this community-based approach came into the world of NGOs or
yes,
PVO.
Because, well, the answer to that is that numbers of these students who came from NGOs.
That's right.
So that this, and we encourage them to, the students with NGOs, to involve their own organization and it was very important for them to go and sell this to their and enlighten the people, their own organization. The beauty of the Rockefeller Foundation staff was that they were selected as outstanding people in their own field. We were limitless. Do whatever you want to do in your own way, and you're taken care of. And that's what both John Grant and John Gordon, they cashed in on that. They took major steps forward that nobody else had done before.